chair is on her way here right now and is going to be arriving a little bit late. So we have a pinch hitter. We have Ross Valori, who will call the meeting to order.
Thank you, Mary. And I'm going also controlling slides here. So we'll get that to the agenda. I want to say welcome to everyone. Thank you for all the folks that were able to make it. We also have a pretty good group here in person. Wonderful to see you all. It is now 2:04, and I call the April 30th meeting of the Universal Healthcare Commission to order. I'd like to give a warm welcome to everyone joining us today for today's meeting. Mary, could you please take the roll call?
Here I am. Chair Vicky Lowe. She said we are expecting Vicky to join us. We know that Joan Altman was unable to attend today, so Laura Kate. Is Laura Kate here? If so, please
Hi,
unmute
Laura
yourself.
Kate Zeichkin is here.
Thank you. Jane Beyer.
Here.
Senator Annette Cleveland.
Present and participating virtually.
Okay. Nicole Gomez.
I'm here.
Dave Eisminger.
Hi, I'm here participating virtually.
Dr. Tao Kwan Get.
Virtually present, with apologies that I'll need to leave at 3:30. Thanks.
Thank you. Vidisha Mandal.
Yeah, hi, I'm here.
Okay. Representative Lisa Parsley.
Here.
I say, you managed to walk in the door before I got to the P's. Omar Santana Gomez.
Present and here virtually. Good afternoon.
Representative Joe Schmick.
I'm here today. Thank you.
Okay. And Mohammed Shidane. Mohammed has been in touch with us. He is traveling and in a very far away time zone with not a great connection. He did share some comments that we will share later, but he let us know that he would not be able to join us today. Back to you.
Thank you, Mary. We will now turn to the review and approval of the February meeting minutes. Is there any discussion of the meeting minutes or proposed changes that any commission members have? Hearing none, is there a motion to approve the minutes? So moved. Is there a second? Thank you.
Second.
All in favor? Perfect. All in favor, say aye. Any opposed?
Aye.
Hi.
Aye.
Thank you. Any opposed? Excellent. Motion is approved. The February 12th, 2026 Universal Healthcare meeting minutes have been approved. And now we will transition to our public comment period. Apologies while I get us to the appropriate slide here. As Mary had noted, we have transitioned to using Microsoft Teams as our video platform for our meetings. We have a quick breakdown here of some of the tools and differences between Teams and Zoom. Again, when you raise your hand, we should be able to give you access to your camera and your mic, and you will just need to unmute yourself prior to speaking. So if you have any issues, please let us know and we'll try and work with you on that. Okay. I'll send it to you, Mary.
Thank you. We had some folks sign up ahead of time. We will hear those comments first, and then we will turn to people in the room, of people who have not, perhaps not signed up ahead of time. What we heard last time was when we unmuted people or trying to enable the unmuting, we got the feedback, well, it was gray, and then suddenly it worked. So there might be a little bit of a delay. So in order to try to move things along, pardon me, what we're going to do is give everybody unmute power all at once and then go through the list. And if your unmute doesn't work quite right, we promise to come back. So we might do things a little bit out of order from what people signed up, but we will get to everybody. And the first person who signed up to provide public comment is Lawrence Richards.
Hi, can you guys hear me all right?
Yes, great.
Perfect. All right. Well, what I wanted to say, I hope is sort of short and sweet. I just wanted to offer that I think I imagine like a lot of people, the current state of government in I don't know the U.S. especially, it's hard to find things to fill me with hope. I didn't grow up in Washington State, but I do live in Washington State now. I grew up in Vermont, and actually Vermont's effort towards universal health care both made it to and died in a sort of similar commission to this. I I'm hoping and want to remain hopeful that this commission is able to create some substantive legislation out of this effort. I appreciate the effort that you all are putting into this, and I I often look at it as a position of I think there's a lot of good intention, and I'm I'm really hoping, wanting to hold on to hope that this becomes something that is behavioral rather than just intentional. Thank you.
Thank you. The next person who signed up to speak is Chris Curry. Chris, here.
Hi, I'm Chris Curry, retired RN from Spokane and member of Healthcare for All Washington Policy Committee. So on behalf of Healthcare for All Washington, I would like to express our support for the reimbursement guidelines as listed in today's meeting materials. In particular, I want to thank you for modifying number 6 to eliminate the idea of using financial rewards and punishments to incentivize healthcare providers. With regard to the universal primary care proposal, I would like to also express our concern that while primary care is extremely important to universal healthcare, now is not the time to take on a new topic and divert attention from much more urgent design components. We think that the $250,000 would be much better spent in other ways, such as by having Milliman complete their analysis of the 3 benefit package options, including an administrative cost analysis of each option. This is needed in order to understand the savings that these packages will provide so that the future funding sources can be accurately determined in an economic analysis. Thank you.
Thank you, Chris. The next person who signed up, I don't believe is in the room with us. I'm not sure. Stephen Field.
Hello, can you hear me?
Yes.
Okay, good afternoon, Chair Lowe and members of the commission. My name is Stephen Field and I live in Federal Way. I'm here today to speak from the perspective from someone who has survived the absolute limits of our healthcare system. I live with multiple sclerosis and epilepsy, and my journey has included surviving a stroke, a heart attack, and sepsis. I've also navigated 3 suicide attempts. I want to be clear, I have had support, but even with support, navigating these life-threatening crises left me in a constant battle against a fragmented system. For the most vulnerable patients, we need more than just access in a moment of crisis. We need universal primary care proposal to provide a foundation of consistent long-term stability. Universal primary care ensures the support system isn't just a safety net we fall into, but a steady hand that stays with us. It allows for the kind of preventive, coordinated care that can help us manage complex conditions before they escalate into emergencies. Please support this proposal to give every resident a stable medical home. Thank you very much.
Thank you for your comments, Stephen. The next person who signed up ahead of time is Kristen Wall. Kristen is in the room with us. Okay, so if you sit at the microphone, there's a little button, and when you press it, you'll see green, and that means the microphone's on.
Good afternoon, Commissioners. Thank you for the opportunity to speak with you today. My name is Kristen Wall, and I'm a Master of Social Work student at the University of Washington, focused on healthcare and policy. I'm also here as someone who has spent years supporting multiple family members through serious illness and end of care. And what stood out wasn't just the illness, it was that constant work of getting care, managing the cost, and fighting insurance denials. And what I've learned is this: it's not the diagnosis, it's the system. Even when you understand how to navigate it, it's fragmented and exhausting. But for people without time, financial stability, or support, it's impossible. Right now, the system decides who gets care based on the ability to pay, not need, and it's getting worse. More gaps, more barriers, and more people falling through the cracks. I appreciate the work that's happening here. These decisions determine whether we're building something new or continuing to manage what's currently broken. We need a clear path to a universal system. We need real financing behind it. We need infrastructure so people can actually rely on it and not something that depends on navigating a patchwork of coverage rules and exceptions. Transitional steps only matter if they're actually moving us towards that goal. And from what I've seen, both personally and in this work, this isn't optional, it's urgent. So my ask is this: be clear about the destination and make sure every step is building towards a system that works for everyone, where access to care is based on need and not the ability to pay. Thank you for your time and leadership.
Thank you. And thank you for joining us today. This next person who signed up I see is online, and it's Sherry McAvoy.
Am I unmuted yet?
Yeah, now we can hear you. Thank you.
Thank you. And this is for when Chair Lowe comes and all you members of the Universal Healthcare Commission. I'm Sherry McAvoy, a nurse practitioner retired, and I'm testifying today on behalf of Healthcare for All Washington. And we recommend that the UHCC consider the following three options for using the $250,000 generously provided by the Office of Insurance Commissioner to fund research to further the Commission's work, like Chris Curry had said. But first, complete the actuarial design analysis to allow the Commission to complete a set of benefit designs for the legislature. The Milliman model previously done needs to be revised to model the Uniform Medical Plan and Essential Health Benefits Benchmark Plan for all enrollees, regardless of income, and to do premium estimates at 100, 95, 90, and 85% actuarial value. Number two, economic modeling to estimate the type and amount of revenue tax sources needed for a universal healthcare system, including analysis or existing funding levels and sources for health coverage in our state, including ERISA, ERISA, Medicare, etc. And third, modeling for strategies to unify our state health care programs to lay the groundwork for a universal healthcare system in Washington state. For example, making all plans at the Health Benefits Exchange a public option plan. We also support the OIC conducting research regarding how the creation of a universal primary care system could be implemented and what its impact on the overall healthcare system in our state would be impacted. We have provided written comments about the questions, components of the research for OIC to address in their study. Thanks for your consideration for these recommendations.
Thank you. The next two speakers who have signed up ahead of time, I know are in the room with us because I can see them. Next is Thomas Kennedy.
Hello, my name is Thomas Kennedy, and I'm a volunteer with Whole Washington. I want to focus on the need for single-payer universal health care here in the Commission. We cannot continue honestly talking about using insurance companies for anything other than temporary administrative support. Time and again, they have proven themselves to be bad faith actors that increase costs for Washingtonians. The cost of healthcare rises proportionally with privatization, and this occurs around the world. It is tempting for this commission to work on a smaller solution like universal primary care. There are, however, significant risks in this approach. It will undoubtedly set back the progress we have made towards defining a single unified healthcare system. It also focuses on the least financially lucrative side of healthcare. This can, in large part, be seen as a gift to the private insurance industry, taking away the least profitable part of it. I truly believe we are all here trying to improve health outcomes for Washingtonians. Having said that, last session proved that our legislature does not yet feel the need to act on cuts coming from the federal government. We need to work together, government and advocates, to change away from complacency and move now to protect people. I encourage the commission members to work with the community to help us all move towards the goal we're looking for, which is universal health care. Thank you.
Thank you. And Andre Stackhouse.
Is that the button? Okay, great. Hello, Commission members, and thank you for the opportunity to meet in person and give public comment today. For the record, my name is Andre Stackhouse, and I'm the Executive Director of Whole Washington. We are looking forward to the Commission's November report and continue to offer our support in any way appropriate. We are hoping to see a clear recommendation on governance for Washington's universal healthcare system. While we have explored and compared many proposals with our stakeholders, we believe that the core principles should be a governance board that is nonpartisan, citizen-led, and small enough to make consensus-based decision-making easy to achieve. We continue to be impressed with the model being developed in Oregon. We will have more detailed proposals to share later this year. Thank you.
Thank you. Okay, those are all the folks who signed up ahead of time. Thank you very much. We now can open it up. If you would like to make a comment, an online person, there's a little hand in Teams, and if you click that, that raises your hand. Or folks in the room also, if any of you would like to speak, please just put your hand up. Okay, we can start with you. I think the mic is still on, so you're good. And please just state your name and your affiliation.
Hello, my name is Nova Dubé, and I am just a resident of Washington who is I at least subscribe to the Whole Washington email newsletter, and I just wanted to kind of voice my support for a universal healthcare effort in the state of Washington. I think it's vitally important that we do so. With the United States spending per capita so much on healthcare and the outcomes relative to other countries in the world spend less, being so different in the sense of they're paying less for more. Us being one of the richer countries in the world per capita doesn't seem to really translate that well to our actual quality of care, and a universal healthcare system would assist massively with lowering administrative overhead and improving outcomes for everyone in the state, as well as providing a level of quality of care across the population, so it's not as disproportionate with some people having really good health insurance and some people not. So I just wanted to use the opportunity to voice that. I'm a mechanical engineer who works in the Puget Sound, and it is probably one of the most infuriating things in the world, the healthcare debate, because when the rest of the world has already kind of moved on from the issue of universal healthcare and is more just trying to figure out a way to make it better, we are still stuck on this subject. And the state of Washington pushing for a state-led initiative would be ideal. And I just wanted to, say I support any effort that gets us closer to that, because the taxpayers of the state, the constituents of the state, as well as anyone who's undocumented or any person in the state of Washington ought to have good health care, because that is a human right. So, and I feel like that's just, makes sense. So, yeah, I think that's all for me, but.
Thank you. We're going to go to one of the folks in the room, and then Maureen, I see your hand, and Christina. So we'll start in the room and then go to the other two raised hands.
Hi, my name is Waleed Afzal, and I am affiliated with Whole Washington, the 37th Legislative District Democrats, the DSA, and Transit Riders Union in Seattle. From my perspective, people do not get health care because it is expensive. They fear getting medical debt. There's just a lot of reasons why people don't want to get health care, including dealing with administration. It results in us having way more things that could have been prevented, way more ER visits, which are incredibly expensive and put a lot of strain on our medical. And it could have been prevented if we had something good in place, especially with primary care, with preventative care that comes from your primary care providers. And with the less excess deaths and lost work days from people having conditions that could have been prevented, we can maintain a broader tax base of working people who get to keep their jobs because they don't get disabled that quickly with better health insurance. And furthermore, if we effectively nationalize our primary care and our insurance, we can keep money within Washington state and within Washingtonians' hands rather than some person far off land who don't really pay taxes. And personally, I think we should have Washingtonians manage Washington's healthcare because we're the ones who are at stake. We're the stakeholders. Thank you very much.
Thank you. Next person, we will go to Mo Brinkland.
Thank you very much. Thanks, Mary. And my name is Maureen Brinkland, or Mo, as Mary affectionately called me. And I'm the co-chair of the HUCS subcommittee, which is part of Healthcare as a Human Right, which is a large coalition of healthcare advocates, including many of the people in the room and previous commenters today. And the HUCS members would like me to forward this message to you, commission members, per today's agenda, and that is to please not use the long sought after and finally gained OIC funding to address the newly proposed concept of universal primary care. Universal primary care is something we can all aspire to, truly, but there is no proof that this new concept is feasible, nor that it's going to be able to function as a transitional step to the truly universal healthcare system that we are all here to support. It may be a sidetrack or even an impediment to the Commission's ultimate task of universal healthcare financing. HUCS members would like to have the OIC funds used to study a financing proposed for the proposed universal healthcare system in order to measure possible overall costs and benefits it would produce. By financing, we mean an economic analysis of how to pay for universal coverage, economic as opposed to actuarial, of which there are many already done. And I have a list of questions here I've given before, but the answers to these questions would show the state and its residents can benefit from a universal system and also be used to gain statewide support and attention needed to get this across the board. Thank you.
Thank you very much. We have one more hand that is raised, and that's Christina, forgive me, Sarabia. If I mispronounced your name, I apologize.
Close, Sarabia. Can you hear me okay?
Yes, thank you.
Okay. Yes, I am from Central Washington. I'm part of a coalition called Yakima Valley Healthcare Defense Partnership. And I just wanted a personal statement around what my Congressional District 4 is going through now as we are coping with the change in our healthcare system. We are rated one of the poorest districts in the state of Washington. We have the highest rate of Medicaid users, the highest rate of children in poverty, the highest rate of uninsured individuals. We are going down fast. We're partial rural, suburban kind of mix, but we really need help and we need it now. So my plea to you is urgency. There are people that are going without and having healthcare ramifications of the changes that are going on with Medicaid cuts, Medicare cuts, or Medicare eligibility changes, and the ACA going away. So urgency is what I'm asking for, and please don't forget Central Washington, Yakima. Thank you.
Thank you very much. Okay, this will be last call. Thank you for all the hand in the room. Please walk up.
Great. Thank you very much to members of the Universal Healthcare Commission. Chair Lowe, I don't think she's here yet, but thank you for allowing us to give public comment today. My name is Catherine Lewandowski, and I'm a semi-retired registered nurse and the board vice chair of Whole Washington. I'm speaking again regarding your discussions around universal primary care, which last month I did speak in favor of at the FTAC meeting. On its face, it does make a lot of sense to try and reduce the cost of healthcare overall and improve outcomes by finding and treating disease early. I do have some concerns, though. First, I fear that it doesn't really reduce the administrative burdens embedded within our healthcare system. This is not only an unnecessary financial burden, but also a drain on the time and resources of our current providers. It's the part of their profession that they currently detest. Secondly, it offers a way to continue the influence from third-party middlemen whose sole incentive is to skim financial resources from the system while providing no real health care that leads to improved health. In this regard, it continues to force Washingtonians to deal with for-profit health insurance companies for emergency and specialty care, where we often have no ability to have any real choice in who those companies are. When choice is taken away from consumers, it removes an important aspect of capitalism that powers the market to lower costs and improve customer services, including quality of services. My father was a businessman, and our family came from a small business background started by my grandfather. They always stressed the importance of customer service. If you don't take good care of your customers, you will not stay in business. And so I have no lost feelings for an industry who's been turning customer service into an exercise in torture and manipulation. So this plan for universal primary care must be part of a rapid process of replacing our current for-profit predatory model of healthcare with sustainable, comprehensive, nonprofit healthcare available to all. Like a stepping stone in a raging
Catherine,
river, it offers no
we're
real security
30
for
seconds over.
Washingtonians.
Please wrap up.
And we must continue forward to the next stone quickly to get safely to the other side. It is scary, and you have to keep your eyes focused on the goal if you really want to arrive safely at the destination you've chosen. Thank you all for the work you do.
Thank you. Okay, thank you. I don't see hands online or in the room. Am I missing anybody? Nope. Okay, that wraps up our public comment, Ross.
Thank you so
we have
much.
one more hand, actually.
Oh,
I see
My
Garrison Bliss.
apologies.
Late
Sorry
comer.
about that. Please go
Hand
ahead,
just
Garrison.
went up, and we are promoting Garrison. One second.
Okay.
Garrison, you can go ahead.
It looks like Garrison still may not be able to unmute themselves.
I got it.
There we go.
I'll even show you who I am here. Hi, I've been listening for a while to this. This is the first time I've attended one of these meetings. I'm somebody who, in 1997, created a form of primary care that could operate on without insurance entirely. That was affordable to normal people, and was not seriously impossible for people who are in middle class, lower middle class, and even poor people to do. It's called direct primary care. It was invented in the state of Washington, and it is now in all 50 states. It is growing at roughly 20% a year. We have over 1 million patients, and we've been studied on many, many occasions. We are now working mostly with self-insured employers because they have the kinds of incentives that would make this work. The thing I can tell you for those who want hope is that primary care can be not only remarkably good, but it can also reduce the cost of the rest of the healthcare system by 20%, which vastly outweighs whatever money you are paying to it. We have lots of evidence that that's true. We don't have to have any input from anyone else we've actually had to fight off government for the most part, including the insurance commissioner here, but who is, I think, now in alignment with us. I just want everybody to know that this is a model that may be adaptable to what you're seeking, which is care for everyone. And if you're smart, I think you will start with a primary care model, because without primary care, everything else will fail. So thank you for listening to me. I just want you to know we're out here, and if you think you have an interest in this, I'd be happy to speak with you.
Thank you.
And I think that wraps up all of our public commenters today. I just want to say thank you. I think this is our new record. I think between written and public comments, we approach nearly 20. So we greatly appreciate that and recognize public comment as an essential part of this process. Commission members review the comments in advance, and we'll refer to them throughout the meeting. So again, we greatly appreciate the comments that you provided. So I will transition us to the next tab here. I think we can do them quickly. So the next item on our agenda are state agency report out. So we'll just go through our commission members and get some quick updates on some business that's occurring at our sister agencies. First, I will ask Laura Kate if there's any update you would like to provide.
Yes, thank you. Hi, everyone. Laura Kate Zeichkin with the Washington Health Benefit Exchange here on behalf of Joan Altman. Our hot off the press information is that we are preparing to release our spring enrollment report for plan year 2026 for the individual market. What we're seeing today is that due to the federal changes to the marketplace, including the expiration of enhanced premium tax credits, we have about 40,000 fewer folks enrolled with the Health Benefit Exchange compared to this time last year. Those who do remain enrolled on the exchange continue to face an affordability crisis. About 50,000 fewer Washingtonians are receiving tax credits for those who are staying enrolled on the exchange. And it could have been worse. This is something that we are looking into more as far as the impact when we look at these enrollment numbers and we look at those who dropped insurance coverage from this year to last, or from last year to this year, excuse me. But because of a lot of the interventions that happened with partners around this table, including the insurance commissioner, and others, we believe that we may have been able to cut the estimated enrollment losses to the individual market in half. That said, we are anticipating significant attrition over the course of the year as folks have a hard time paying their higher insurance premiums. We also, as we look out, some of the most restrictive federal policies that are affecting access and affordability for exchange customers begin next year. That includes changes to tax credit eligibility for our lawfully present citizens. People who are denied Medicaid due to work requirements will also not be eligible for tax credits on the exchange. And then further out, we are going to be unable to auto-renew customers during open enrollment time, which will potentially cause pretty significant continuous coverage barriers. So with all of those changes, we are expecting still, even with these mitigations that have been very critical for our environment in 2026, we're continuing to look toward a potential 30% drop in enrollment over the next several years. And likely those are folks who are going to be uninsured in Washington state. So we remain committed to understanding who is staying enrolled and who's dropping coverage. And we also remain committed to creating mitigations to keep Washingtonians covered despite the access and affordability barriers that are being put in place via federal policy change.
Thank you so much, Laura Kate, for that great update from Health Benefit Exchange and all you're doing to preserve those benefits. Next, I'll turn to Jane Beyer with, yeah, sure, go ahead.
Thank you. My question is, when you get this report out, are you going to be able to give us an estimate of what that 30% loss of enrollment equates to in terms of budget? In other words, if the state was able to backfill that, what would that look like for the state? Just so we know the numbers that we're talking about instead of hand waving.
What it would cost to cover folks, just to make sure I'm clear.
It's sort of the backfill question.
Backfill the
Mhm.
enhanced premium tax credit
Yep.
specifically. Yeah, we can provide that information. I don't have it off the top of my head.
No, that's fine.
I do believe our original estimate last year is that about $275 million is being lost in enhanced premium tax credits.
Thank you.
And Ross, I just want to jump in for 1 second. Just want to note that Chair Vicky Lowe has joined us.
Excellent. And I'll now turn it to an update from Jane with the Office of the Insurance Commissioner.
Thanks, Ross. Laura Kate, remind me, the 275 loss was assuming or not assuming premium alignment? Do you remember?
The 275 lost is not assuming premium alignment, is my understanding.
Yeah, that's what I thought too. Okay.
Yes.
So in terms of updates, what Laura Kate is referring to is when the health insurers were setting their rates for plan year for this year, the Office of the Insurance Commissioner directed them to make certain assumptions, actuarially sound assumptions, I would note, about how much the health insurers would have to pay out to people who are eligible for lower cost sharing under the Affordable Care Act. And I would note that about 2 weeks ago, the Office of the Insurance Commissioner made that policy, that premium alignment policy, permanent going forward. We are awaiting every year the Center for Medicare and Medicaid Services puts out a rule for how the individual market is going to operate in the upcoming year, so for 27. And we are waiting for that final rule. There are definitely a number of things in that final rule that we are very concerned about, some of which will probably ultimately get challenged in court again, just like the rule last year was challenged in court. But it adds to the concerns that Laura Kate expressed about the impacts that we're already seeing of HR 1 and the end of the enhanced premium tax credits. But
Jane, we have a question from Representative Schmick as well, when you're able.
Absolutely. Rep Schmick.
Thank you. Real quick, I'm sure that you've got a paper about premium alignment. Could you send that out so I understand that concept? Thank you.
Absolutely. We are happy to do that. So we will do that. And so we adopted that rule. And as Laura Kate indicated, we think it reduced the enrollment loss from individual health coverage by half. So thank God for that, at least. And we are probably most notable, we're doing rulemaking this interim, so during this period between now and the end of the year. And I think from the perspective of this group, there's a piece of legislation that was passed in 2025. It's House Bill 1432 that is a bill that strengthens our enforcement of mental health parity laws, also opens up access to some mental health services. For example, no prior authorization can be required for up to the first 6 visits for mental health or substance use disorder treatment and has a number of other really good consumer-friendly protections. We'll be developing the rules to implement that law, and it's effective January 1 of 2027. And then I'll hold off on other things until we talk about universal primary care.
Thank you so much, Jane. Now I'll turn to Dr. Kwang Get from the Department of Health if you have any updates.
Thank you. Yes, just a few quick updates. The first is about measles. Our agency put out a media release today talking about the growing number of measles cases in our state. We're up to 40 cases, and 3 have an unknown source of exposure, meaning that it's likely that undetected spread is occurring in the community. Another update I wanted to give is on our HELMS system. HELMS is Health Enforcement and Licensing Management System. This is our electronic platform. And this new system modernizes our healthcare licensing and enforcement processes, means less paperwork, it means better security, and means centralized information that's easier to retrieve. And this is a development that's a long time in making and hugely important to maintaining an effective healthcare workforce, which of course is critical for healthcare access. I guess the final note I'll leave is that, this is a difficult time for the public health system in our state, in that there's continuing to be a lot of challenges from many different directions. There continues to be instability and uncertainty at the federal level. We're navigating budget cuts and layoffs from a number of sources, such as the end of COVID funding, reduced state revenues, reduced indirect funds. And so we are having to make difficult decisions about what kind of activities we can continue and what activities we need to stop to adapt to these new budget realities. But healthcare access is one of our agency's 2 top priorities in our state health improvement plan. And so we are definitely orienting for the future and looking for ways that we can increase our engagement with the healthcare system. And that's the end of my update. Thanks.
Thank you so much, Dr. Kwang Get. And next, we'll turn to Dave Eisminger at the Healthcare Authority for any updates.
There we go. Hi, everyone. I have 4 brief areas to do some updates on. We'll start with Apple Health, aka Medicaid, and a lot of work that is going into place right now to prepare for the big shifts in 6-month renewals and work requirements that are changes in federal policy from last summer. And so those begin kind of officially in January 2027, but the agency is in the process even of looking into some of the hiring processes and training that we will need to have for the eligibility determination staff. And so we're kind of in the throes of that kind of infrastructure changes that need to happen, which then leads into Q3 when client notifications begin and outreach and training begins because of the first determinations that have to be in place January of 2027. So that's kind of one body of work that I thought would be helpful for this group to keep in mind as moving along. Then the Rural Health Transformation grant. Wanted to highlight that applications have been posted for the Community Advisory Committee, and work is underway on some of the initial contracts that were identified in that application. We have hired the Rural Health Transformation Director and are bringing more staff on board within the 3 relevant agencies to develop those contracts and future RFPs. Shifting to my third topical area, which is Cascade Select, the public option. We are in the middle of the annual renewal process with the 3 existing carriers, and those renewal applications are currently with the carriers, and the rates and responses to those are due in the latter half of May. And then we are off on the process with our 2 sister agencies, OIC and the Health Benefit Exchange, to land everything for 2027 plan year, but that's where we are in the Cascade renewal process. And then when it comes to the other commercial work at the Healthcare Authority, also known as the PEV and SEP programs, we are also in the early stages of our renewal process for 2027. And so that's very similar to the Cascade Select. process. At least we are in the receiving exchange of information with the carriers as we gear up for the rate setting process for plan year 2027. For the PEB and SEP programs, that process happens in the Public Employee and School Employee Benefits Board public meetings usually in the June and July timeframe. But we have some of the pre-work obviously before we get to that public discussion of rates. So that's just a quick high-level overview of a few things that are happening every day at the Healthcare Authority.
Thank you so much, Dave. And now we'll turn to Omar Santana Gomez with the Office of Equity for any updates.
Hey, Ross. Good afternoon, everyone. No updates from the Office of Equity at this time.
Great. Thank you, Omar. Now I want to open it up to any additional commission members who'd like to provide any updates of healthcare-related information that you think would be helpful for commission members and the public to hear. And I'll just give folks a minute if you want to raise your hand if you have anything, or for those folks in the room. Okay, not seeing. Oh, Senator Annette Cleveland, please unmute yourself and go ahead. Thank you.
Thank you very much. I appreciate it. Just want to take a moment as a member of this commission, as well as chair of the Senate Health and Long-Term Care Committee, to share, given that the legislative session just ended a few weeks ago, that we very much made progress on passing important legislation that addresses the challenges, some of the challenges in front of us that have already been discussed today. I want to mention that we protected our healthcare safety net with passage of Senate Bill 5981. We made sure that Washingtonians have access to vaccines and medical services that are actually based in science, rooted in evidence through passage of HB 2242. We also protected access to HIV medications. We expanded access to reproductive health care and set up permanent funding sources for reproductive health clinics that provide really important healthcare services, such as Planned Parenthood. So I just want to share also that, as we've heard from our agency reports, policymakers as well continue to focus in the interim on implementation of HR 1 and the timelines that are before us that were set out in that federal legislation. We are continuing to collaborate with our governor's office, agencies, and others to work to maintain access to as many people as we possibly can within our state. And want to also finally share that, that we also don't lose sight of our ongoing existing goals that include the work of this Universal Healthcare Commission and our bipartisan healthcare goals as a state around access, affordability, and quality. So recognize that we are in very challenging times, but just really grateful for everyone engaged and committed to these efforts. So thank you.
Thank you for that update, Senator Cleveland. I'll just take one more moment to see if there's any other commission members who'd like to share an update. Not seeing any. Now I'll hand it over to Pam McEwen to give us an update on last month's Finance Technical Advisory Committee. And also just want to note Chair Vicky Lowe is here, so I'll be transitioning those duties back to Chair Lowe. Thank you. Pam, please go ahead.
Yeah, okay, thanks. And I think I might be able to help you make up a little bit of time. It's been we're just a bit behind schedule. So if, can we go to the first slide? So you'll see that our agenda looks a lot like your agenda. And so we are syncing very closely in terms of our work. And so I'm going to go through these topics. So beginning with the next one, we'll just give you a few brief updates about public comment. And like you, we start our meetings hearing from the public. We heard support for how the OIC proviso funds could be spent in terms of analyzing financial models. We heard support for universal primary care as a step towards broader universal coverage. And we heard some opposition to linking reimbursement rates to quality metrics and provider reimbursement guiding principles, which actually came back today. And we were able to modify those principles, I think, in a way that captured what those concerns and questions were. And then there was support for a public corporation model rather than managed care organizations. Next slide, please. We spent the bulk of the time of our meeting on the universal primary care proposal. And if you have time, it might be worth a listen to that discussion. We heard a really excellent presentation from Jane Beyer, who kind of walked us through it. And then we really opened the floor to let the FTAC committee members who bring a wealth of experience to this topic just to kind of have at it and ask questions and talk and push back. So Jane is going to be covering that in her presentation, which comes after mine, and I'll have an opportunity, I think, to chime in a little bit on what some of the comments and interests were. And then we talked about provider reimbursement. So there were further revisions to provider reimbursement proposals and the guiding principles, a request from the commission to create a roadmap for reimbursement mechanisms, which we talked about at our last meeting, which I know was a bit of time ago, but we did discuss that when I was with you last. And that's something that will be moving forward over the next meeting of the FTAC. And there will be more discussion of provider reimbursement at the last part of today's meeting. So we'll have a chance to come back at that again with you today. Are there any questions for me? Looks like Representative Schmick.
I have 4, but do you want to tackle them now or later on? I guess that would be my question. I was reading through both the appendixes and I had some questions. When would you like to do those?
Are these on reimbursement, provider reimbursement?
Yeah, and some of the terms used. So I can write them out and send them, or how would you like to handle these?
I know that Harrison Fontaine is presenting later on that topic. We'll have a more in-depth discussion, and maybe his presentation may answer some of those questions.
Okay.
So I'm going to ask
That's
Harrison.
fine.
Yeah, that's what I was going to suggest. Thank you, Rep. Schmick.
Okay.
Later in the agenda, Harrison's going to be going over it in more detail. And as Pam said, some of your questions may be answered, or that might be a better time to pose the questions.
Yeah, that's my hope, is that in his presentation, we'll take on some of those questions. I actually am curious to hear what they are, so I hope that you will take the time during the meeting to bring them up. Any other questions? Okay, I'll hand it back to our chair.
Hello. Sorry for being so late. Thank you, Pam. Always appreciate you stepping up and helping be the liaison. If you can go to tab 5 in your packets, we're going to have Commissioner Jane Beyer describe a proposal for universal primary care. That proposal could become one of our transitional solutions on the path to eventual universal health care. And we have a number of people who will help describe the proposal. Is that right? Mm-hmm. Mary will start us off with an overview and background.
Thanks, Vicki. We can go to the next slide. This is going to be a multi-part presentation. So I'm just going to give an overview of how we plan to walk through this idea today. I'm going to really frame it up at a high level at the very beginning with the questions and what today's goals are, a little bit of background of where this idea has been discussed in the past. Then I'll turn it over to the folks who know the details, the details of the universal primary care proposal. Also, as Pam mentioned, she's going to share some of the FTAC feedback from their last meeting, talk about work plan considerations if this is adopted as an interim solution. Jen will talk a bit about OIC proviso, and then we'll talk about next steps. So that's a lot of ideas and a lot of people. The next slide. Ultimately, the question to the commission will be, does the commission want to adopt this proposal as a transitional solution on the path to a universal system. We're not expecting an answer to this today. There's a whole lot of detail and information. Some has been shared, some has not been shared, but that's sort of the ultimate question that we'd like to work toward. And more in the near term is, well, how might this OIC proviso fund support exploration of this proposal? So if you're thinking long-term, thinking closer term, what we really hope, and I'm saying we as in HCA staff and the folks who work with the commission, what we really hope to get out of today is, first of all, to give everybody a chance to talk about it and ask questions and learn more. And for us as staff to learn what's the additional information the commission needs to start making these decisions. What can staff take away? And, figure out, do we need a work group? How do we go about this? But, what are the questions and what's the information we can bring back to the commission? So the next slide is just a really quick background. This idea was first proposed to the commission as a possible transitional solution during the February meeting. As Pam mentioned, it was presented by Jane at the March meeting of FTAC. That's a link to the March meeting, and that's a timestamp to the presentation and discussion if you'd like to go listen to it. It's minute 33 of that meeting. And the next slide. And this does align with other initiatives around Washington and initiatives in other states. This slide is just to give you a little bit of context. We have the Healthcare Cost Transparency Board, and that has an advisory committee on primary care. There's primary care transformation initiatives within the Healthcare Authority. Other states have proposed bills that are like this idea and not quite like this idea. I mean, it's similar enough that if you read the links, it would seem familiar, but these are not exactly what is being proposed here. Worth taking a look if you have the time. And a lot of people who favor this idea say this is a good way for states to achieve their primary care spending targets. Washington has a target of 12% of healthcare spending to be toward primary care. All right, and this is where we get into the proposal overview. So I'm going to stop speaking about background. I'm also going to pause to see if Commissioner Patty Kuderer would like to offer any remarks.
All right, thank you. Yes, I would. I appreciate the opportunity. Good afternoon, everyone. I want to thank you first for taking time to discuss the concept of universal primary care. I've been listening to all of the comments and really appreciate the different perspectives. And as I've always said, I'm a great supporter of universal health care, and I see universal primary care as a foundational first step to that system. So we're all aware of how important it is for patients to seek preventative care and detect any issues early, rather than waiting to seek care when they're sicker. And I'm hopeful that you will consider integrating this concept into the Commission's work this year. So I'm looking forward to a robust discussion and hearing more of your comments and your questions, and really appreciate your time. Thank you so much.
Thank you very much. And now I will turn it over to Jane to talk about this in more detail.
Thanks, Mary. So first, I want to say thanks so much to the folks who've already, including the FTAC, asked a lot of really good, thoughtful questions about this concept. I had a chance to review Healthcare for All's comments, and I think one thing that jumped out at me more than anything else to the long list of questions that were presented about universal primary care as a concept is how many of those questions, over half, would need to be addressed in order to design a universal healthcare system. Just really fundamental aspects of the system. And I think that's why the commissioner is referring to this idea not as an alternative to universal healthcare, but as a foundational step toward universal healthcare. So with that sort of intro provided, the concept here, and this is still very much in development. Every time somebody asks a good question, we're like, yes, that's a good question. So please don't assume this is set in stone. As Rep. Parsley and Rep. Schmick and Senator Cleveland know, nothing is set in stone. There are always lots of discussions. But conceptually, essentially, this would be a universal primary care benefit that would be carved out of the traditional healthcare system. And it would have the consumer's other health insurance essentially wrap around this universal primary care benefit. And we do know, and Dr. Bliss referenced this, that there is abundant evidence out there that access to comprehensive primary care over time reduces emergency room utilization, reduces inpatient hospitalization, helps people be adherent and help manage their chronic disease, and equally important, helps people prevent ever getting chronic disease. And so those kinds of ideas are really sort of core to this. And we also have a lot of evidence about primary care, advanced primary care models that work. So, for example, there's a collaborative care model, which is homegrown. It was developed by folks at the University of Washington, which brings behavioral health providers, social workers, community health workers into primary care offices so that those individuals can be there in real time when a primary care doc is presented with somebody who's suffering from anxiety or depression. And rather than saying, go back to your health insurance company, look at the provider network, try to find a therapist, to say, please go down the hall to the therapist that's down the hall. And so when we're thinking about primary care, we are thinking about integrated primary care. We are thinking about building on the work that the Primary Care Advisory Committee to the Healthcare Cost Transparency Board has done related to how we define primary care. But many of you know I was formerly the Behavioral Health Commissioner, and I have taken every opportunity, both then and now at the Office of the Insurance Commissioner, to just keep pushing on access to behavioral health care and how critical it is. And I think we can go to the next slide. Another issue that has come, we have had lots of discussions with docs over the years, and one thing that we hear over and over and over again is, I have 12 different contracts with 12 different insurance companies, and each of them wants me to report on a different set of quality measures. And I'm spending my time and my staff time on doing that. And so the concept here is there would be chosen initially a small core set of quality measures, and ideally, rather than the providers having to pull and report those measures, we have various data sources in Washington State that hopefully we could rely on to pull those measures for those things. Really, really critically, clinicians would make decisions about what services people need and the care that they need. We think that it is very important to have a very strong corporate practice of medicine element to this, so that the primary care docs are the ones who are deciding what somebody needs and how much time they need to spend with them, and not a corporate entity that's somewhere else telling them how to practice. The concept is to have what we call capitated provider payments. So the physician would receive for each patient that's attributed to their practice a certain amount every month, so they know the revenue's coming in. They're not doing after the fact fee-for-service billing. And the idea is having predictable revenues so that, for example, a practice can say, yes, with this predictable revenue, now I can hire a social worker and bring a social worker into my practice, which has been a big challenge for a lot of primary care docs. And we know that there are a number of things that really have to be thought through with respect to how you're paying the docs. For example, how are you going to attribute a patient to a doc? That is one thing. Number two, there might, for example, we heard from somebody in Yakima who talked about the greater healthcare needs of people in the Yakima community. Do we need to do some sort of a risk adjustment method so that physicians who have a heavier burden of patients who are older or who are sicker get higher payments. And we understand too that it's a lot to ask a primary care provider, especially an independent primary care provider, to essentially, quote unquote, take financial risk of saying, yep, I'm going to get this amount of money per month. And for those of you who are as old as me, back when we first implemented Medicaid managed care in Washington state, in order to incentivize plans to come in and act under the program, the state actually provided some reinsurance. And so I think there's a concept here too around, would the state need to provide some sort of kind of umbrella, reinsurance umbrella, so that primary care providers were more willing to come into the system? Is there another slide, or is that it?
The next slide may be FTAC. Hang on. let me
Okay.
look.
And so,
Yep.
right. And so the one other thing that we were talking about too is we are acutely aware of the primary care provider shortage. Raise your hand if somebody in the last 3 months has asked you about the fact that they can't get an appointment with a primary care provider. Yeah, right. So we're acutely aware of that. And the thinking is that in order to incentivize primary care providers to come into this system, there are things that can be done, such as some of you may have heard about the Project Echo program or a program called PAL, the Provider Access Line. And with those programs, a primary care doc can pick up the phone and talk to a specialist and say, I have somebody in my office, they're complaining about X. I'd really rather be able to treat them myself rather than send them out to a gastroenterologist where they're going to have to wait 2 months to get an appointment. Can you help me figure out what to do? What should I think about prescribing? What's the best next step to order? So having a service like that available, having support, sort of technical assistance for developing an advanced primary care practice, any number, creating more incentives for, we now have, fortunately, the osteopathic medical program in Yakima, and we have WSU. So what kind of incentives can we have to churn more family practice docs out of the now 3 medical schools that we have in the state? So workforce is definitely a component of this. And the goal is, if you build a model that allows a primary care doc to practice the way they were trained to practice and to get adequately compensated, that will sort of generate in itself more interest and increase in the number of primary care docs and ARNPs and physicians assistants. So that's it.
Do you want to take questions from commissioners now, or should we go through Pam's and then the 2 of you can take questions? Does that make sense?
Whatever you want.
Okay. We will go to, okay, Rep. Schmick, I do see your hand. Do you want to ask your question, and then Pam can tell us a bit more about the FTAC discussion?
Sure. Jane, when you talked about the capitated payment, who holds the risk for those primary care physicians?
That's a really good question. And I think the idea is ultimately you want the primary care docs to be able to have a perfectly viable practice receiving that capitated payment. But as we mentioned, thinking about things like whether you're going to have to risk adjust the payment, whether the state would have to do some sort of reinsurance or sort of stop loss to make sure, especially that the smaller independent practitioners are able to practice under that kind of a model. So lots more discussion to be had on that topic. And then I guess the only other thing I would note too, Rep. Schmick, on that is we know from all the work that the Healthcare Cost Transparency Board has done that currently in Washington state, we spend about 4.7% of healthcare on primary care. And we have a 12% goal that the legislature has set. So we are woefully under that goal. And built into this concept would be transitioning up to that 12% primary care spend.
Pam, do you want to?
Yeah,
Oh, I'm
so-
sorry about
so-
that.
And the FTech probably talked about this, and I'm sure you're aware of it when we're talking about workforce for primary care and the universities that are going to be providing the primary education. Are we including in that the internship and residency requirements? Because that's going to slow you down generating those primary care.
I agree. And I mean, Washington State does have one of the most robust family practice residency programs in the nation. They get applicants from all over the country, but you're right. It's not just the medical school slots, it's the residency slots.
Okay, Mary, do you want me to go ahead?
Yes, please.
Yeah, okay, thank you. So this is a list of things that we talked about, and you'll have already heard Jane, because she heard all these questions. So in some ways, there's been some response already, but there was definite concern about primary care practices that are carved out being able to take on financial risk and how that would be managed. And that was a question that was raised pretty strongly. Risk adjustment is absolutely critical. I think Jane covered that a bit, but how would with these various, multidisciplinary primary care practices deal with the fact that risk would not be distributed evenly among those practices? This is one of the things that was of great concern to some of the members, actually all of the members, is rural healthcare right now, where the shortages are even more acute. And there's less ability to flex to the kind of models that might be designed. So how do you design something that will work in both rural and urban settings and be responsive to the current crises within rural healthcare in terms of meeting coverage needs and long distances that people have to travel for care. There can be potential unintended outcomes, and I think we have seen this in other systems where there you could end up with a two-tiered system where our provider is going to charge extra for extra services that go above and beyond what the model was designed to do. Is there shifting of care or care stinting? So how would the model prevent those things from happening? The proposal lends itself to economic rather than actuarial analysis. This gets to the OIC funding, whether that should be used to, if the OIC funding were used to do some analysis of the primary care concept, would it be better to spend that doing economic rather than actuarial modeling? I will say that there was at least one member of FTAC who kind of waved the flag for actuarial modeling, saying that to some extent you may need to do both. The primary care provider shortage, which Jane just talked about, was raised. And also, I want to note that the shortage of residency spots was also that the training people and the training pipeline that would be needed if you are kind of expanding access to a service when you don't have enough people providing that care. How do you accommodate that, and how do we resolve that issue anyway, that we have a shortage of primary care providers? And then there was strong support for primary care and really strong support for the potential of integrating behavioral health. I want to note that FTAC did not discuss this as a pathway to universal healthcare. That's kind of not our job. That's more your job to kind of figure those things out. So we really honed in on the model itself. We did not discuss some of those bigger issues that were raised in the public comment today. Are there any questions for me about this discussion? Okay, I think back to Mary or Jane.
Well, we were going to talk in a bit about work plan considerations or OIC proviso considerations, but I want to pause to see if there's other questions for Jane before we go on to that, for Jane or for Pam. Let's see, Laura Kate's hand is up and Badisha. So we can start with Laura Kate.
Thanks so much, Jane and Pam. Really appreciate this overview. I get really excited when I think about a proposal that is so bold in its intent to really center access to high value advanced primary care, and to do so for all Washingtonians, not just those who can afford it or have access or have health insurance. And I think that we heard a lot of urgency around access, around affordability. And with urgency comes the need to consider potentially disruptive, bold, innovative approaches like this. I think we received comments that we haven't talked about yet. So Mary, sorry if I'm jumping the gun here, but we received comments from another commissioner who wasn't able to be here today. And I do just want to say that those are really articulated well in thinking about some of my questions and concerns, and particularly would really want to think about what they propose around a primary care proposal that really meets the tests of reducing fragmentation, strengthening, not distracting from the existing work plan, and then also making sure that it's really realistic and feasible. And I would also just kind of think about within those tests that are proposed by Mohammed, how are we thinking about the potential harms to consumers when we think about the potential unintended consequences here around uninsurance, referral patterns, what happens to the person who potentially sees this, does not have that wraparound of insurance, has a screening, does not have a place to go for that screening or cannot afford it, or sorry, for the additional care that might be needed. Also thinking about sort of potential harm to the markets and the healthcare ecosystem or the unintended consequences there. When we think about uninsurance, when we consider higher risk Washingtonians who do stay covered, and potentially some of the driving the healthcare costs there and health insurance costs there even higher. So I think we just want to think about, again, some of those tests, learn a little bit more. As you said, Jane, sort of no bad questions. And I think we'd want to pick this apart and really map it across the system. And I think we'd also really want to have a very clear, strategic, and detailed plan and timeline for a transition from universal primary care to a universal system. So Jane, you mentioned some of those wraparounds or like broader reinsurance model or otherwise, but I think we'd really want to map also what are those buffers around the rest of the ecosystem that are needed while we potentially have a foot on the dock and a foot in the boat at the same time. So really excited about this. We're eager to learn more and just want to make sure that this group is being really thoughtful and mapping out what we would want to see modeled and what we would want to dig into more.
And Laura Kate, definitely appreciate those things. And I think Mohammed did raise really good questions in his comments. And I would just say a couple of things. And everybody knows I'm pretty direct. So Mohammed's last comment was it should be financially and federally realistic. And I think you can say the very same thing and ask the very same thing about moving out to a fully universal healthcare system. So the same concerns that could be raised about universal primary care, whether it's financially or federally realistic, would be applicable to full meal deal universal healthcare. And I think we just all need to be super realistic about that. We've had discussions about what could you do with Medicaid, what could you do with Medicare. Those same questions would apply. And Laura Kate, I totally share your concerns about what about people who are uninsured under a system like this. And I agree that is clearly a concern, but I'm thinking now, and I think the commissioner is thinking now, about the tens of thousands of people who, like the 40,000 people who drop coverage off of the exchange, whose only alternative is to go to a hospital ED if they go anywhere for care. And so, yes, uninsurance is a massive, massive issue. And no, universal primary care is not the full answer to that. But we always think about what's the alternative, right? So just some thoughts on that. But I really do appreciate Mohammed's questions.
I see Badisha has a question.
I have a couple of comments, not questions. So first of all, I think that this is really interesting, very bold to kind of design a model for universal primary care. But I guess my concern is that it's not necessarily a transitional, or at least I don't view this as a transitional solution. And I know we'll discuss that next, because a transitional solution is usually something that is already validated and you are using it because you know that it works. Whereas this one is, starting from scratch, you're actually designing a model without knowing what the behavioral responses would be. So I feel like that takes a lot of time. And I don't know if we are actually moving, or we could have used the time better. I'm not sure about that. So that's the first comment. And the second comment is that about the economic and or actuarial modeling, because it's modeling and we're still discussing financial risks and risk adjustment. To me, this sounds more like a actuarial analysis at this point. Okay. And I think the economic analysis might follow later on, but I don't see this as an economic analysis, and I don't know which one is more important. But just to model this new concept, I think that I see that as an actuarial model. So that's all.
Thank you, Badisha. Dr. Quanget.
Thank you. Well, as a former primary care pediatrician, I certainly am a proponent of the concept of universal primary care. And we heard a lot of thoughtful public comment, and it sounded like one of the concerns was sort of the opportunity cost that that resources and people power and energy devoted to this means less time and energy devoted to universal health care. And what would be the best way to respond to those concerns? Thanks.
So I think that is an excellent question. And the way I think about it, Dr. Quanget, is, for example, looking at the questions that Healthcare for All posed in their comments and seeing how many of those questions would be applicable to a universal healthcare system as well. And thinking about, that's why we're almost thinking structure this in such a way that it's foundational versus transitional. So this is the universal healthcare becomes the foundation that you build the rest of the system on. And so the more questions that you can answer to develop a universal primary care system, the more questions that you've answered that would be applicable to universal healthcare as well. But everybody is absolutely right. It's a matter of degree. It's a big difference in degree. And there are things that would be unique about this. Although even in a universal healthcare system, the questions about how you're going to address primary care, how you're going to address care coordination are all still present. So.
Representative Schmick, your hand was up. Did you still have?
I just don't know if this is the appropriate time to ask questions, since we're primarily talking about a primary care focus. a model here might not be appropriate. That's why I took my hand down.
Okay. Do you want, okay. Representative Parsley?
Mine, you can address this probably in email. It's my curiosity because unfortunately I was in session during the February meeting. The difference between a universal primary care system versus a high value advanced primary care. What is the difference between those? Because I want to make sure they're not just talking points. And is there substance to actually calling it that?
So that's a great question. The universal primary care system, the model for primary care in that system would be that integrated advanced primary care model. So that's part of the foundation of the system.
One more question. I'm sorry. Thank you. I knew you'd have the answer. Worked with you enough. My last one is it's a clarifying to make sure I understand this. When we're talking about our goal of reaching 12% primary care, and we're currently at 4.7%, all the mechanisms you said to increase workforce and everything else would be how we get to that 12%. Is that correct?
Yeah.
I just have a few comments. What you describe reminds me a lot of the Indian healthcare delivery system, and I know we've talked about that over time. And yes, we did, and it's more of a system of care than coverage, right? What we have now is coverage. So I really do think it's hard for us to think differently because we've had this system for quite a while. But for me, it's a little bit easier because I work in a different system of care. So I want us to be mindful of not just pushing back because it's different. I think it's a great idea. I think there are people who need access to care, primary care, behavioral health care. The importance of that is huge. And I don't know, transitional, is it transitional to get more people in coverage? I mean, are we thinking about it in the right way? Is it transitional to get to that 12%? I think so, but those are my opinions, but I really like this idea and am very supportive of how we can move forward with it and really think more about how to get more people into primary care, really. Thank you. Is it Nicole? Oh, Laura Kate, sorry, they moved around.
Jane, I had a more specific question going to the point in the model around clinicians making the decision about services and patient care. Appreciated your clarification there that the intent really there is to make sure that it's based on best practice clinical decision making as opposed to sort of boardrooms making the decision. Can you talk though about that concept within the model and how it aligns with maybe the definitions and performance measures? I guess I'm just worried about the model being a bit open and potentially leading to some of these unintended outcomes where there's sort of the minimum is covered under this model as opposed to maybe the more advanced model that's being envisioned.
So I would say that you would want to be very specific about the model of care that is financed, expected. And I am aware of the fact that over half of primary care docs are employed by either large practices or health systems. And I think Laura Kate, throughout this process, just as the FTAC did, when they said, have you thought about potential unintended consequences, that everybody raised those so that the question that can be had as the model is being designed is whether there are things that you can embed into the model to try to minimize the risk of those unintended consequences, knowing that you will never identify and address every single unintended consequence. That's what happens when you try something new. So.
Thanks, that's really helpful. And I agree about being as specific about the model of care and trying to play it out a little bit more. That's great.
Thank you for sharing, Chair. In that, the goal of this model, do we have a timeline? Like your goal is 12% primary care. Are we looking at timelines on if we're going to do this? And in our model, are we looking at timelines if we're going to use this as transitional versus foundational?
So in terms of timeline, there are a number of ways to think about it. One way to think about it is you're phasing it in by like population or program. For example, we have a massive need for getting care to the people who have lost coverage because of all of the changes that have been going on. And so should that be our first priority? And then we always think about where the state as a purchaser has the ability to do something. So, for example, PEB and SEB, right? Or the fully insured health insurance market that OIC regulates. Or would the Medicaid program be able to carve primary care out of, for example, Medicaid managed care contracting? So one way to think about timeline is to think about the feasibility of applying the model to different programs. So for example, right, Medicare is going to be all the way out here because the feds control Medicare. So I think one way to think about it, and this is not a definitive yes or no, is to think about phasing based upon our ability to do so legally as a state. Which is the same issue that the commission's been grappling with for the past 3 years. That's a really good example of that if it's a decision that would have to be made for both this system and the universal healthcare system.
I want to again bring lessons from the Indian healthcare delivery system, where we have federal laws that require use of alternate resources before using the Indian Health Services funding. And is there a way to do something like that to provide wraparound? So if somebody already has other coverage, and they're taken care of, we're looking at like this level of coverage. And as long as they have that, then they're good. But if they don't, then, you can bring in some primary care in places where they're not getting coverage. That's how you get around the federal stuff, though.
Go on. Okay, so I can go on to talk about some of the work plan considerations which have come up in your questions. Thank you very much. As I go along, please feel free to put your hand up and ask questions. This is our little work plan graphic that we show in every meeting. Usually there's an earlier time in the meeting when we go through this. This time we held it for this discussion. Thought it fit a little better right here. This is where we are, the commission's work, the universal system design components. That's the column down the left. Those are the things that are spelled out in the RCW that talks about what the commission is charged with doing. We have our transitional solutions, and then every year we file a ledge report letting legislature know what we're up to. So the next slide. It's a closer look at the universal system design elements and where things are right now. Eligibility, benefits, and services. That work was done last year. We know that we have to revisit it at some point, but it is done. FTAC right now is working on provider participation and reimbursement. That's what Harrison is going to talk about later in this meeting. Next, FTAC will be taking on financing. And those other three design elements, enrollment, infrastructure, and governance, live with the Universal Healthcare Commission. And there's some target completion dates there of when we are hoping to wrap up each one of these topics. So that's current state, where we are with various design elements. The next slide it talks about, this is our possible revision. This is the big question before the commission. If we add universal primary care as a transitional solution, there it is, it's there in the middle, it's got the red box around it, that's where it would live. So a possible revision to the next slide of what's happening with these universal design elements. And I want to stress that this is possible, potential. I mean, questions have come up and we haven't really been able to, we don't know yet some of the definitive answers, but these are just things to think about. This is also part of what came up in Mohammed's comments. Those earlier proposals may need to be updated to incorporate universal primary care. Is that an extra body of work? Perhaps not, because we know that when we get through all of these design elements, we need to revisit and reconcile. And maybe it's simply a part of that process, or maybe benefits and services, we simply note, we're talking about integrated primary care with behavioral health. I mean, it's not necessarily, what's the expression? Creating something from whole cloth, cutting from whole cloth. It's not necessarily doing that, but they may need some updates. And looking to the things that are in progress and in the future, again, if we have universal primary care as a transitional solution, the proposals would consider universal primary care as a transition. As Jane said, when we get around to asking some of these questions, for instance, questions about enrollment, the answer might be the same. The answer for ultimate universal system and universal primary care system, those might be the same answer. Those might be wildly different answers. They might be kind of close. We don't know. But the reason we are bringing this up is just that there are potential implications for the work plan, and some of our target completion dates may need to be revised. So I will pause to see if anyone has questions, because in a moment, Jen is going to talk a little bit about OIC proviso funding. Okay, here you go, Jen. You get the microphone. Oh, I'm sorry. Was there a question?
I am so sorry. I'm full of questions today. I shouldn't have had
No,
green tea before
very
I
good.
came in. Some of these, would we need to answer or decide, I guess is a better way, going along with the insurance commissioners, we're considering this a transitional program or foundational. Wouldn't that change our workflow as well if we're doing foundation, or do you think it would be the same? In other words, are we deciding this is transitional only and we're not going to talk about foundational?
That to me is a question that the commission could decide. I have been thinking of it as the transitional. Okay. Now on the fly, had you said to me, Mary, think about this as foundational, would this slide look different? I'm not sure. I know it's not a very, very good answer, but I didn't consider it that way. And maybe that's something to be considered. I don't know. Ross, did you want to add something?
Well, I would just add, I think Jane had mentioned this earlier, we would anticipate quite a bit of crossover between any work we would be doing on an eventual universal primary care analysis and scoping and what we're doing currently. They would require all these same components. It would just be a slightly, smaller scale of that. So I think Jane said it best. I think it's a matter of degree, how much we're kind of transitioning away from these. I think these would still be the essential building blocks of a universal system and or a universal primary care system. And it'll just be the degree, that we need to deviate from this to be able to incorporate some of the primary care principles. So I know that's not an exact answer, but I think we would cover the majority of these elements in both scenarios.
Yeah, and these basic elements, this list you see, that list of elements isn't going to change. Depending on whatever system we're building, whatever we're calling it, however we're designing it, these are the pieces as agreed upon by commission and earlier work, and also laid out in the RCW. So those ovals don't change.
But what you're saying is that if we do this, that we have to go through all of the different system pieces for the transitional solution, right?
Right, that you're looking at.
Mhm.
that you're looking at what, if anything, of those aspects would be different if you're starting with primary care and then building out versus building out the whole thing. Yeah.
Right, and as Jane pointed out, they may be the same or essentially the same. I mean, they may be the same or incredibly close.
Thank you. Next slide, please. The OIC proviso money has been mentioned a few times already in the meeting, but just as a reminder of what it is, it's $250,000 of the insurance commissioner's regulatory account to be used for economic, actuarial, or other modeling related to the design of the universal healthcare system. And the funds must be spent by June 30th, 2027. Next slide, please. And these were the assumptions that were decided on prior to the universal primary care proposal being brought up, that the final deliverable would provide guidance for making the recommendation, but wouldn't be the recommendation itself, would be related to one of the design elements that hadn't already been completed. And the commission did discuss this at the last meeting and identified provider reimbursement or financing as the two areas to use the proviso money to explore further. Next slide, please. So in terms of, this is really intended to be a discussion and capture ideas that that the commission has. The question is, should we be using the proviso funds to do an economic or actuarial analysis related to exploring an aspect of the primary care proposal? And what questions do you have that you think might be good candidates for this proposal? And I would say we probably don't need to finalize this today. I don't think, it sounds like we're probably not ready for that, but just to start capturing ideas and a discussion about that. Anyone have any thoughts or suggestions?
I am so sorry. All the questions these days, I'm sort of in my brain, and maybe I'm too simple. That first bullet point is assuming we are doing a universal primary care. And then the second is what else if we don't do that? Am I correct?
So I think there are two ways to look at it. I mean, one way would be to use the proviso money to maybe decide if we were pursuing primary care. The other way would be if the commission is ready to say that the intention is to pursue primary care, then we could be looking at how would we do it, some aspect of how would we look into it. So I see the difference.
And so maybe another way to look at it is there a way to use the funding to, with respect to reimbursement and or financing, and think about it potentially from both a primary care and universal perspective. So stay true to the intent to say we need to spend some really serious time thinking about reimbursement and financing, but doing it in a way that could potentially capture both, because so many of the questions are the same. And you could model two scenarios, right? One where you assume that you're spending 12% of expenditures on primary care, and how does reimbursement work with that, or how would you finance it? And then you're also assuming the full meal deal. So the question is whether, I know actuaries love to give you various scenarios to work from. So maybe something like that could sort of hit the sweet spot of addressing both. knowing that $250,000 in actuarial speak is bupkis, as we say where I grew up.
Yeah, so in that example, the already identified areas of provider reimbursement and financing would potentially continue to be the areas identified, and then it would just be looking at the details of would we be able to do something that covered both?
Representative Schmick has his hand up.
Thank you. I guess my question is very simple. Who do you anticipate? Who's in, who's out? Who would this apply to?
Thank you, Rep. Schmick. I think are you referring to past work we've done defining eligible populations?
On those primary care system, which we're discussing.
Oh, okay.
I'm sorry, it wasn't clear. Who do we anticipate would be in? Who does it cover? I mean, just a basic question.
Right. And I think the goal, Rep. Schmick, would be that it's universal, but also there was a lot of work done around eligibility for a universal system and sort of what populations could be in, could not be in, depending upon federal law, et cetera, et cetera. So it might make sense for the commission to essentially say, okay, let's revisit eligibility. Here's where we landed with respect to eligibility. If the commission wants to take up the universal primary care concept, then say, does it make sense to apply those same decisions around eligibility to a universal primary care? It just Rep. Schmick, because of the vagaries of federal law, right? So.
Well, I understand it's an ongoing issue about who's in, who's out.
Mm-hmm. You're correct. And I think the idea is and I think this is sort of a concept in the eligibility, in the original eligibility work, is we work on who we can get in right now, and then we think about the steps that we need to take to bring in the populations who, by virtue of federal law, we're not able to bring in at the outset. So again, kind of that concept of phased.
And Jane, if this universal primary care benefit is not, everyone is eligible and it wouldn't be considered insurance, do you think that would have any implications for who's eligible to receive it?
It would. I mean, and that would be the legislature's decision about financing, right? Do you essentially want to say, okay, everybody who's Medicare eligible, you're Medicare eligible and you get all your Medicare benefits, and distinct from those Medicare benefits, we're going to fully fund a primary care system, right? Or do you say, we're going to bring in the people who we can bring in, and we're going to work with Congress, whoever, and CMS and whoever else, to bring in the Medicare population at the point where we're able to realize some Medicare revenue to support the system.
Thank you. That's great.
Nicole?
Hey, I think this is actually an interesting pathway. I was trying to make it make sense in my head, and I was thinking about like universal primary care being more like the floor of a building, right? That's the guaranteed like baseline of care. And then the transitional piece would be the full building, right? You're still going to need the first floor, but you're also going to be adding to the building as you move along. I think it's an interesting idea, and I'd like to learn more about it. I wasn't able to attend the February meeting because of a session, but I'm really curious on learning more.
I'm also wondering about like FQHC models too. We think about like the HRSA 330 FQHCs and how they get some base funding and then they get certain payments like encounter rates for the people they see. So you're like funding the actual building, you know, the cost of the hard cost, but then they're getting something also for seeing patients. And again, if that could help get around some of the Medicare things. Sorry.
If I was to voice an opinion, and I'm not saying that's just how I will vote, but having sat on two of the budget committees in the legislature, I think this has to be tied to financing, especially since we're looking at some really tough couple of years before we even if we see the millionaire's tax revenue. And if we're going to try to implement this quicker, I worked with a lot of people last year trying to help with backfill, and it was very, very difficult. And if we're going to implement this sooner than what we expect the millionaire's tax, we need to have a model for that as well as after, because there's a millionaire's work group being put together, and that needs to be on their radar if we do end up with this revenue. So in other words, I would like to see some of this money spent to give direction to and ideas to the legislature on how we can fund this, because it'd be great if we had a plan, but then we can't fund it. That's where my concern is.
Senator Cleveland and then Nicole. Oh, never mind, Nicole.
Thank you, Madam Chair. I absolutely believe that our primary care has to be the backbone of our healthcare system, and it's something that we've grappled with for a long while now in terms of how to better achieve that. So I am very intrigued by this proposal, very excited about it. I too, though, relative to some of the other questions that have been asked, I'm struggling a bit with how do we define the community who would be the target of this model? And so, I think that Jane and you've provided some good feedback there. I'm still trying to kind of get my arms around that. So I have two different questions. One of them does pertain to this model and whether primary care would be then an essential benefit that we add to the state. And of course, that involves federal agreement as well. So I'm curious about that, or am I thinking about this model in the wrong way? And then my second question, which is unrelated, but has to do with the question before us around an economic analysis. I'd just be interested in a little more discussion around what are outcomes of an economic analysis would be expected to be. What would we want to see from that?
So, Senator, to your first question, right now, primary care is already part of our essential health benefit package or benchmark plan. And I have been noodling the question of whether we would have to think about a 1332 waiver in order to make sure that we could do that carve out, but there would still be sort of advanced premium tax credits going to help fund it. And could you do anything with pass-throughs? So it's a really good question. And it's one of the things that's on my list of things that we need to think through. And then, in terms of economic analysis, those are really good questions. I'd love to talk to some economists about what they think would be feasible and what you could get out of it. Like, what assumptions do you need to have going in around what your per member per month cost is going to be, and how many years you have to wait before you can make assumptions about savings in the back end, right? Like savings on ED utilization or inpatient hospitalization. Those are all really, really good questions for health economists.
Nicole, did you still have a question or comment? All right. Back to you, Mary.
Thank you.
Go ahead, Laura Kate.
Thank you. I think I just wanted to reinforce what Jane was talking about earlier and was mentioned really when you think about how this analysis would fit into the broader work plan and advance not only the foundation that Nicole said, but like kind of the building of the rest of the building. And so I think that the principle of what should be explored, it should be applicable to sort of the broader universal healthcare model, as opposed to anything like very specific around primary care. It seems like that would be an important principle to advance the broader work while also potentially exploring this as a transition.
I think the next slide is going to take us toward the break, wrap us up a little, start looking at next steps. Thank you, everyone, for presentations and questions and the public comments earlier. This has all been great as we're trying to flesh this out. What I said early on was we as staff hope to walk away with knowing what kind of information the commission would like to hear to aid you in making all of these decisions. And I do have some notes and they may be off base, so please jump in or correct me or whatever, talking about whether this idea is foundational or transitional. Maybe we need to include the plan for how we would move from universal primary care to a full-blown universal healthcare system. Talked a lot about actuarial and economic modeling, what it takes to phase in universal care by population or by service. You know, right now we're talking about primary care, and Rep. Schmick was asking about, you know, who is in and who's out. So maybe we look at that eligible population, but over time, you know, who gets added, what gets added, maybe is a question worth exploring. Looking at economic analysis or looking at the topic of the proviso funding, whatever it is that is explored, it should be applicable to both universal primary care and to an ultimate universal healthcare system. And also, I'm going to get this wrong, so legislators jump in, economic analysis providing information to the legislature specifically about financing and, you know, exactly how this would be funded. Did I capture that?
That's perfect, because what will happen is, unfortunately, that part of it will not go to the healthcare and welfare committees. It will go to our budget committees. So
Okay.
it needs to be very specific unless you have someone like me who's on both.
Okay. So are there other questions, other topics that I missed? A little bit of a hodgepodge there. Go on, Ross.
Well, I'm just going to go back a few slides here. Curious too if commission members have any comments related to these assumptions that we're kind of going into much of the analysis here, particularly the first, that the final deliverable will provide guidance for making a recommendation, not the recommendation itself. Meaning, if we were to proceed with this universal primary care proposal as the topic for the actuarial economic funding, that we would wait until we receive the results of that analysis before deciding to proceed further with the proposal, or if you know, we would choose to move on regardless of what the analysis comes back as. And I think that sort of speaks to the foundational transitional solution question as well. But again, just wanting to call these out in case commission members have any questions or comments related to these.
I just also thought there could be different ways of interpreting the word recommendation. If is the recommendation about an element, or is it about the larger primary care versus universal health care?
Yep, thank you. Then the very last thing, we just threw out a lot of big ideas and a lot of big questions. and we're not a huge staff. So we're hoping that there's some work group potential in here. Part of what we thought of a couple of things. Maybe it could be a joint commission FTAC work group. You mentioned health economists. A lot of expertise in FTAC. And are there specific topics that we can assign to FTAC? I mean, aside, we can have this work group, but we can also have like, oh no, FTAC, please figure this out for us. And I don't know if there are volunteers for work group, ideas about a work group, ideas of what should go to FTAC.
And Mary, could you talk a little bit about what the expectations for that work group might be? I think we had talked, potentially some of these questions we've identified, work group members would assist in trying to provide preliminary answers that would then be brought back to the commission, maybe at the next meeting to try and address, or at least move this conversation forward. But if there's anything additional.
Yeah, it's typically meetings happen in between commission and FTAC meetings, staffed by a member of the HCA staff. We like to start the work groups with a very, very specific set of questions that we are addressing. We come up with a schedule, as Ross said, probably bring some answers in June, and then June, July, August. Actually, the next commission members meeting is early September. It's not in August, it's September 3rd. So June meeting, September meeting, and it tends to be iterative, bringing things to the commission, more questions arise. And also there are FTAC in the months that we don't have commission meetings, we have FTAC meetings. So it could also be working with FTAC folks as well. But we try to keep the time commitment minimal because we know we're asking for time from very busy people. And we try to do a lot of staff work in the background and have people move the questions forward.
So a thought, I think that, right, we already know a lot about primary care and advanced primary care models. There are things that we already know about. I think when we had the discussion with FTAC, they legitimately focused in on, if you're going to do a capitated payment model, how do we need to think about risk adjustment? Do we need to think about some sort of risk sharing or reinsurance or whatever? That seems to be up FTAC's alley. And that kind of discussion could, if the commission decides to do the kind of any modeling that involved, a universal primary care component, would, I think, help inform that modeling. So to think sort of iteratively about how FTAC could think things through, put together some recommendations to the commission if the commission does choose to take the route, that would then inform whatever modeling is done. Does that make sense to you? Okay.
Thank you.
And just one additional note on the work groups, these work groups would not be under the Open Public Meetings Act. So the meetings would occur, in between a scheduled commission and FTAC meetings, and they would, perhaps even through email. So it's a little bit more flexible and allows the work to proceed at a little bit quicker pace to be able to bring back to these meetings. So just for folks' context.
Thank you.
I assume the commissioner, I will check with her.
Okay. Thank you very much.
If it sounds like we're begging, we are. We very much, look to commission and FTAC members to help answer these preliminary questions to bring back. So would very much appreciate. And I see Nikki has her hand up.
I'm happy to participate. I'm just still trying to figure out exactly what path we're going down as a group.
And I think if I'm tracking, part of the job of this work group preliminarily will be to kind of do this initial scoping and trying to address this first round of questions that we received as we move towards a decision on whether we pursue this or not. But happy to be corrected, Mary.
That's correct.
Yeah.
And we have some FTAC people in attendance today, so we can always try to get FTAC members onto this as well.
I'm happy to
So
help.
thank you, Nikki.
Thank you. I think that if there are no more questions, I think we can go to our break. I don't know if anyone has last minute questions.
And I see we have a hand in the room from one of our public members. And this is our Universal Commission meetings, our open public meetings. And the time for public comment is just that limited public comment period. The other times are for commission members. So very sorry. And I should have explained that better in the beginning. So my apologies, and happy to try and address it after the meeting.
But we're going to go to break, so.
Yes, yeah, good timing.
And you also
Are we
can-
taking the full 10 minutes or do we need to? Oh, yeah.
I was going to say, you can also send us comments in writing to the general mailbox and we can chat.
Do you want to do the full 10 minutes or?
Yes. why don't
Okay,
we do 10 minutes?
back at 4:20 then. All right, let's come back together to finish our meeting. All right, welcome back, everyone. We got a lot more to talk about here. If you turn to page or tab 6 in your packet, we have our last topic of the day, and Harrison Fontaine will share the latest proposal for provider reimbursement. Harrison.
Thank you, Chair Lowe. All right, hope everyone had a good and well-earned break. We are going to cap things off with provider reimbursement. So we're going to be talking about a few things here. Just to give you a quick overview, we're going to be talking about the work products that are working their way through FTAC and the Commission regarding provider reimbursement and participation. We are going to talk about the guiding principles that have been referenced a few times in this meeting and hopefully get to a vote on those. And then we are going to take a look at the draft proposal, which is in Appendix B of your packet, and are going to ask for some review and feedback on that. All right, let's go to the next slide, please. So to describe what these work products are a little bit, we have 3 documents now. So we have the guiding principles, which really are key values, and they're meant to inform not just this proposal, but also future regulatory decisions in a universal system. Also, we have sort of the core of it, which is the design element proposal itself. This is a set of recommendations, essentially payment mechanisms that can be started at a small scale and broadened over time after incremental measuring and certain decisions are made. And then we have an implementation roadmap. And the way the implementation roadmap relates to the proposal is, while the proposal is sort of building blocks, relatively high level descriptions of what these payment mechanisms and implementation approaches could be, the implementation roadmap is very specific. It defines currently 2 pathways that we could walk down as Washingtonians to get progressively closer and closer to that universal design. And also along the way, get our arms around cost containment. All right, let's go to the next slide. So here we are in late April, and we started provider reimbursement around January. FTAC has had a lot of good discussions on it. We've done a lot of work in a work group that includes Bob Murray, Roger Gantz, Pam McEwen, and
Eddie Rouser.
And Eddie Rouser. Thank you, Mary, for the save. So here we are in April, and the plan here is to get your feedback before this goes back to the work group and to FTAC for one final turn of the wheel before it comes back to the Commission for a potential final vote in June. We also have those other documents winding their way through as well. So let's get to the guiding principles. So you'll find the guiding principles in Appendix A of your packet. And again, what these are high-level things that should be woven throughout the proposal itself and sort of all of the other accompanying documents, essentially things that we're trying to make sure of as we go forward with provider reimbursement and participation. And Ross, would you actually be able to go to Appendix A so that we can take a look at those before a potential vote? Okay, so here they are, and because they're a little bit small, I will read just the top line of them off so that we're all on the same page. So there are 10 reimbursement guiding principles. The first is to create a uniform and consistent reimbursement system across all payers. The next is to improve affordability of the healthcare system. The next is to maintain and improve access to needed care. The fourth is to maintain and improve fairness and equity of the reimbursement system. Fifth is to rebalance payments to support traditionally underfunded care, here especially thinking about things like primary and preventive care, behavioral health services. The sixth is one that we've worked on quite a bit, which now reads supporting clinicians to improve care. That incentive language has been removed. 7 is to standardize key aspects of the system. And can we go back up to 8? Thank you. 8 is to assure the reimbursement system's transparency and accountability. 9, to assure reimbursement system stability and predictability. And finally, 10, to ensure that the payment policy aligns with capacity policy. All right, so there you have them. Before any potential votes, I want to make sure that we have time for questions. Do any of the commissioners have questions regarding these draft reimbursement guiding principles? And I should say, a vote here would not mean that these are set in stone. Like any of the other documents that are winding their way through this process, we will have time later in this process when all of the design principles are essentially in place to come back and do a reconciliation and an alignment of all of our final documents before they make their way into a final recommendation. So any questions?
Harrison, can you go back to number 10 and explain it a little bit?
Of course, and I think we've had questions on this one before, so thank you for calling it out, Jane. So here, I'll read the next sentence here to get us started. To integrate and coordinate payment and healthcare capacity and staffing policies to ensure adequate access to affordable care. And I think Bob Murray's on the line as well. He might be able to speak to this a little bit, but I think the idea here is that in some respects, sometimes you can have aspects of policy that are trying to enhance affordability being at odds with those that might expand access and capacity of a system. So here, a good example might be, for example, in Maryland, the rate setting commission being sometimes at odds with decisions with their certificate of need program. So things like that would be one example, but I'm not sure I'm fully addressing your question. Does that sort of get to what you're asking?
Yeah, I think so. And I'm just tired because it's the end of the day, but so I might understand it tomorrow morning.
Thanks, Jane. And always happy to follow up. And again, I think we have Bob in the audience, and we can feel free to promote him if he's able to give any clarifying descriptions. But let's go to Rep. Schmick.
Thank you. Just a simple question, since I live in a rural area. It all comes down to payment for those doctors. I mean, if you don't pay enough, I talk to the recruiters who are recruiting docs or PAs or ARMPs to the area. And when they tell me with the current reimbursement model, you literally cannot afford to put a doctor in some of these smaller hospitals and smaller places. This is a great theory, and it's wonderful, to sit here and yeah, we like the goals, but boy, at the end of the day, it comes down to dollars and cents. And I guess I am concerned about how this will play off or play out in underserved areas. Thank you.
Thank you very much for that, Rep. Schmick. And, I think to start off on answering that, these principles that you see here are very high level. We spent certainly a lot of time on them, but our aim was to hone them so that they could guide the other documents that are a little bit more specific, a little bit more descriptive about how we would approach implementing these things, including how we would really mitigate the risks, especially to rural and underserved populations. I'm not recalling which principle it is, but that is certainly one of the core tenets of these principles, making sure that, as we advance affordability, we don't sacrifice access, and seeing our rural communities as one of those places where the rubber meets the road, and we have to be very mindful of how exactly we would implement these payment mechanisms in those communities. I'll also say that we have some excellent folks in FTAC that have spoken to those exact concerns, and it certainly is something that we're wrestling with. Are there any other questions on these principles? Seeing some head shakes.
I just have one, and I don't mean to be a broken record, but how we reimburse the doctors in the system is ultimately tied to how we fund the system. Is there any way to do like a circular statement saying that that has to be kind of a back and forth to that portion of the state budget? Because one is going to inform the other and then back and forth. Do you understand what I'm saying?
I think I do. Yeah, certainly the two were sort of, intertwined to a degree that they can't be separated. And so, as we've gone through drawing up these documents, FTAC has certainly had to consider, what belongs in this document versus, an eligibility document, an infrastructure document, a finance document, which, that financing design element, I think, is really what you're getting at. So,
I guess I'm trying to avoid a stranded policy. So and it can be just something really 60,000 foot kind of a statement, just so because it's a guiding principle. I want all of us who are creating this to keep in mind, we have to find the money.
Certainly. And just to make sure I'm understanding, you would like that reflected in these design principles explicitly. Is that correct?
The reimbursement guiding principles. And it could be really like, pie in the sky kind of statement, but it's just a reminder for those working in the system, there has to be a connection.
I guess what representative I think is saying is that they're not mutually exclusive.
Thank you. You're right on. Thank you for clarifying for me.
Thank you very much for that. I appreciate that. And I think that, perhaps if what we're looking for is a minor adjustment, we might be able to do that edit on the fly. I'm thinking about Principle 10, which aligns with capacity policy. Ensure payment policy aligns with capacity policy. Would there be a way that you might suggest, appending something to that to, finance policy as well, or am I perhaps missing your point here?
No, capacity does seem right. And I'm hoping that Jane can give advice. I just saw her.
How about aligns with policy related to health system capacity and financing?
There you go.
I love it. All right. So, not quite sure what the exact approach here is, but hearing that there's some broad agreement on Jane's suggestion aligns with capacity and finance policy. Is there any movement in the room for a vote or for further amending these principles? Nikki.
I move to adopt the principles.
And the principles as amended?
As amended, yes.
Thank you.
Second.
Harrison, the words were aligns with policy related to health system capacity and financing.
Thank you very much, Jane.
You're welcome.
And staff will make sure to circulate an updated version of this after this meeting.
All right, we have a motion and a second. Is there any discussion? Any other discussion? All right, all those in favor, please say aye.
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 Any opposed, say nay. Motion carries.
Fantastic. Thank you all. Okay, so moving to the next, essentially, work product as part of this package. In Appendix B, you have the draft version of our current reimbursement proposal. This is something that I hope reflects the work of FTAC and the work group as well. And there's been a lot of good thought in this. So I'll walk through the sections at kind of a high level, and please, I know that there are already some questions about this, and so happy to clarify as we go along or whenever is appropriate. So in terms of the sections, we have the summary and background does a few things. It introduces the document, but one of the things it also does is talks about why a lot of this document focuses on transitional solutions, transitional payment mechanisms that don't quite go all the way to a universal design all of a sudden, but get there in incremental steps. And the reasoning behind this is really that to increase the feasibility of a universal system, we first have to get our arms around cost containment. And a lot of these payment mechanisms start to do that for us. In terms of the payment mechanisms themselves, there are sort of two broad categories here. We have price and spending regulation. That includes things like hospital global budgets, bundled payments, and reference-based pricing, to name a few. And then we have leveraging state purchasing power or market power. So essentially tying together different purchasing pools within the state and getting essentially better deals for the state in that way. Next, we have phased implementation approaches. So while these payment mechanisms, well, that section is relatively agnostic to how we would go about implementing these, the implementation approaches describe very broad ways in which you might begin to expand a payment mechanism, whether it's by market segment, so going from a small part of the commercial market to the entire commercial market, or by including new patient populations, et cetera, et cetera. And then we get to provider participation. And we had a lot of discussion as a group about this. And really what it breaks down to is two different things. We think that in the early phases, there are some incentives that may induce providers into these different payment mechanisms. So for example, with reference-based pricing, in Washington right now, we have a payment floor for primary care in that sort of small segment of where it's being implemented. And so, if primary care providers can get higher reimbursement rates, that might induce them into participating in these payment mechanisms. Things like that around the margins might help for sort of ramifying and strengthening the system in early phases. But ultimately, the group sort of came to the decision that mandatory participation, especially late in the game, is really important. And the reason for this is laid out in that proposal, but essentially the highest paid providers are the ones that you really need to bring into the payment system to ensure cost containment. And if they can opt out, you won't have meaningful cost control. Lastly, we have an oversight and data collection section of the proposal, which doesn't talk about governance broadly, but about how data governance would work, about how data would be used to oversee this payment system, to potentially decide when to expand a payment mechanism, things like that. Also, there's an allusion there to a provider registry, which would go a long way to sort of allowing us to use our all-payer claims database, which currently tracks all of the payments or some meaningful portion of the payments in Washington state, and allow us to really look at how those map onto meaningful provider groups. And then lastly, there's a section about alignment with ongoing work. So that was a lot. Without diving into the text of that proposal, I want to pause here and make sure everyone is clear on what's included in the proposal and offer a chance to answer any questions. Rep. Schmick.
Thank you. I have several questions and comments. First of all, I'll start at the top of my list. In the transitional cost containment strategies, and you referenced reference-based pricing. In Oregon, when they've been doing this hospital system was close to a 5% positive margin. And after the changes that they made now, including reference-based pricing as a system-wide system, they are now negative. In Spokane, Providence, in the hospital, they have two hospitals up north, Chewelah and Colville. The changes that the legislature made, including reference-based pricing, 3 years ago, Providence was running a $140 million deficit. They cut that to 80 the next year. They cut it to 20 last year. With the changes the legislature has done, that 20 now moves to 81 million. Multi-care is 27 million. I guess my concern with in these, when you talk about the transitional cost strategies, it seems to me that there's potential to do a lot of damage. And where I get really concerned is that when you have to move patients from critical access hospitals, which I have 9 of them in my district, is there going to be a spot, these bigger systems, when they need to move them? Because they won't make it work. And that often means less people, less doctors, less care, and less spots open. So I really worry about that. And also talks, and you talked about in there, you referenced to hospital global budgets in that. Has there been, I've got a couple questions about them. Where has this been done that's been done successful? Do we have someplace to look at to see? Secondly, as I understand it, each code is defined that we're going to do these many things for, let's say, code 100, and we're going to do a list of 5 things. If we're outside of that list, we've already brought up care shifting. Pam brought that up earlier in her presentation. There are limits to the global budget, and that's why I ask, has this been implemented someplace else where it has been successful? Do you know of a place where this has been done?
Thank you for that, Rep. Schmidt.
Well, I have more, but I thought I'd
Yeah, thank you.
stop there.
Yeah, certainly a lot there, and definitely hearing the deep concern for rural communities and how working through these payment mechanisms does have its risks. And first of all, just before I forget, I would be really interested in that paper I think you cited with a hospital in Oregon going from a positive to a negative margin.
Yep.
Would love to include that in our write-ups, as we want to be very upfront about these risks and allow for real policy conversations about how to mitigate them. Certainly, we know that when it comes to access, the cost of care is certainly one of the main things that can be a barrier to care, but certainly we also want to be mindful of how these payment approaches would affect rural communities. To answer your question of where has it been implemented, certainly internationally in several contexts, but I also know that Maryland has had hospital global budgets for quite some time now. In other states, they were once a thing, and they were sort of rolled back quite some time ago. And my knowledge of the Oregon essentially experiment, something very similar to what we implemented through 5083, they've experimented with down in Oregon. And my understanding there was, broad strokes, it did not destabilize hospitals. But I would certainly, hearing your concern here, I'd like to revisit that literature, both on my own and with the work group.
Okay, if I'm sure that you've got some modeling or tests or report that's been written about Maryland, if you could supply that to the commission, that would be helpful. And another item that was brought up in the Appendix B was leveraging state purchasing power, and it referenced quality as one of the issues. What would be different than what they're already doing through the Medicaid system now, where there are matrix and levels that have to be done? What do you envision differently here that would be actual savings to the state that we're not already doing?
Mm-hmm. Yeah, fantastic question, and something that certainly we'll hope to clarify in that roadmap document. So very broadly here, part of this is linking together different purchasing pools. So, PEB, SEB, and then there are aspects of the exchange and Medicaid. And so the idea here, right, is pulling that market power could allow for better prices, for better essentially contracts, and also importantly, instead of an RFP process, this would be open competitive contracting, where essentially the state could, if it chooses to do so, and this is something that I believe is already used in aspects of Cascade Select. Right, they can sort of set a very discrete set of terms, quality metrics, quantity, whatnot, really describe what they're looking for and have, all comers bid in a competitive fashion for that, and that the state would, within those guidelines, take the best rate, and that would allow for cost savings. Certainly would hope that our written document will do more justice to the idea, but I think that that's the broad concept. And yeah,
Well, I guess we will see what you come up with. My last question, and it was alluded to, and I don't understand what it is. A public corporation model. What does that mean? That would be the mechanism for applying or doing this. I just wanted some clarification on that.
Yeah, interesting. I'm not actually recalling public corporation mentioned
Pam spoke of that because I wrote it down when she talked about it.
I see. If I'm following correctly, this might be the public corporation concept that Oregon has put forward, where the risk-bearing entity would be a public corp that isn't quite a government entity, but is certainly tied in several ways to government regulations and whatnot. But I think perhaps others in the room can give better a better explanation of that. Health benefit exchange might be another example, but I'll stop there.
Would that be further explained in what you present at the next meeting? Because I don't mean to ask a lot of questions, but I always have a lot of questions.
Yeah, really appreciate the questions. So I don't want to speak out of turn for what these documents as they come back after working with FTAC and the work group will include, but certainly I can promise that if a public corporation would be essential and part of that document, we would explain it well.
Okay. Thank you all for indulging me in my questions. Thank you.
Thank you. Really appreciate the thoughtful questions and comments. I see
Nicole has her hand up.
Go ahead.
Yeah, I just had the public corporation model was brought up at FTAC's public comment period. So just for clarification there.
Thank you. And I think just to add a little bit more context there, I think it was a public commenter suggesting that Washington pursue a public corporation as part of its universal design, but that certainly wasn't deep in the discussion that FTAC had itself.
And just to add on, Harrison, I believe discussion of kind of what the risk-bearing entity would be in this eventual system will probably fall more into the infrastructure governance conversation. So not sure if that will come out in the provider reimbursement proposal, but it will likely, well, it will be discussed when we discuss who the risk-bearing entity would be for this eventual universal healthcare system.
Thank you, Ross. All right, if there are no more questions, we can go to what I think might be our final slide. Thank you all. Well, here are some questions for you all. Two specific questions when we are thinking about this proposal, and certainly they might have already been covered in some respects from the questions we've received already. The first of which, should the draft proposal describe reimbursement mechanisms for every service type? So this proposal, again, is relatively high level. It talks certainly about hospitals. It talks about primary care to some degree, specialty care. It does not go deep into some of those. Certainly doesn't touch pharmacy spending. So the question here is, would you like to see this document be sort of comprehensive in what it addresses, or is a more sort of targeted approach acceptable in this case for the purposes of the commission? And I suppose I'll suggest that the default here would be, if there are no asks for us to include something else, we'll stick with what we have currently, but certainly would be open to including more content.
So I think Harrison did, and I was just skimming. I did not do my homework. I apologize. When I was skimming, it looked like it referenced under resource services like primary care, behavioral health, rural. So you did address that, right?
Correct. Certainly briefly, but yes, it is in there and certainly something that we're considering pulling out a little bit more in the roadmap document. So thanks for calling that out.
Okay. And then on the second one, should providers be allowed to opt out of would opting out of the payment mechanism mean they're literally opting out of the entire system?
So that's a good question, and not something that we discussed. So I might have to take that out or take
Okay.
that back to
Uh-huh.
the work group to really discuss what the implications, excuse me, of opting out of, for example, a hospital global budget system would be.
Uh-huh.
I think you would be able to design the system in a few different ways, right? You could imagine them opting out without any penalty, which would just essentially mean it's optional, or they could opt out with, the requirement that means they don't receive any payment from the universal system. So we will take that back, work on it,
Thanks.
and come back with a better answer for you. Thank you, Jane. And Representative Schmick.
Well, I would want to follow up on the opt-out portion of this, unless there's some meat on the bones where, providers are going to have to choose. It sounds like if it's going to be mandatory, we've got their head over a barrel and not the best way to do medicine, I would suggest. So we've got to really think through that portion of the policy.
Okay. So hearing that, we need to be very descriptive about how these, especially hospital global budgets, would be implemented in rural communities, and how we might mitigate risks to those communities and systems. Is that roughly what you're saying there, Representative Schmick?
Yes.
Okay, thank you. We can work on that. And certainly, again, I know it's a little hard to keep track of with 3 different documents all saying slightly different things, but certainly the specificity that the proposal lacks, we certainly hope that the roadmap will bring ever more meat to the bones of what we're doing here, so that this can be as helpful as possible for the Commission. Any other comments here? Okay, I think I have one more.
Sorry,
Go ahead.
Harrison,
Vicky's
this
hand
is
is up.
Vicky.
Sorry, can't see in the room. Go ahead, Vicky.
Well, I know, and just following up on that thought of like opting out, but I'm hoping that we're building a system that providers are going to opt into, because we'll have administrative simplification. They'll know what to expect. The payments will be expected.
Certainly.
So
Certainly,
yeah,
and there are lots of trade-offs here, especially when we're considering going from our current system to something pretty darn different. And there are many potential advantages for rural hospitals with things like hospital global budgets, prospective payments, consistent payments, being able to plan ahead, and sort of the rubber meets the road where we sort of set those funding levels. And we've had some really robust discussions about that.
Yeah, and if they're not at the mercy of the insurance carriers who like to deny first and then maybe pay later if their feet are held to the fire. I think if they can expect to be paid and they know what they're going to get paid for. I don't know if we need to if we need to force them to be in the system. I feel like they're going to want to be in the system because it's going to be better than what we have.
Mm-hmm.
And
thank you. And that was excellent. I agree with you, because it got me thinking about some of the bills that we saw and didn't necessarily get out of committee or off the House floor or Senate floor is, for example, that insurance companies will radically change contracts with very little notice, and trying to give stability to the providers. It may actually make it so they prefer that. And so in this draft, Are you looking at contract durations and notifications for them? Because this is a huge issue, having heard it in committee. Because
Boy.
just that, being able to go, I know once a year, the state's going to come back and give me a contract, and they're not going to change it in July when they said they would change it on December 31st.
That is a fantastic point. Kind of a new one for me. Not something that we have actively discussed in the work group or in FTAC, but certainly something that we can consider folding into that roadmap document, especially in perhaps the proposal as well. Thank you for the suggestion. Seeing a few other hands. Rep Schmick.
I guess the thing that concerns me about this in not being able to opt out is that I've been around the legislature enough to know that when budget times get tough, we roll back reimbursements, and we've seen it. And that does happen. We talk about the insurance companies, but the state does it too. And that's why I think there has to be options for the providers in the hospitals. We talk about a surety for them. I think there's a risk for them also in the way the state operates.
Thank you for that. Certainly, really appreciate the comments here, and something that we'll bring back to the work group as we move ahead. And Ross, I see you have some thoughts as well.
Yes, well, noticing we have an additional hand up from a non-commission member, so encourage, again, apologies, but this current discussion is for only commission members, and we accept public comment during our public comment period. So again, apologies, and happy to take your comment via email or at the next commission meeting. Thank you.
Certainly.
I think the question is when we define successful as far as like rural hospital global budgets, maybe being clear about what successful means. Does it mean corporations making money? Does it mean patients have access to care when they need it? Does it mean we have to wait in the ER for 2 hours or 4 hours before we're seen because I need a stitch in my finger? I think what is it we're looking at that's success? And I really fall on the side of access to patient care.
Certainly, and sort of the evaluation criteria for some of these payment mechanisms is something that we're considering, including in some way, shape, or form in that roadmap document. And hearing that, I think we'll go ahead and try to include that. So thank you.
Right, and one other thought, Harrison, sort of when I was talking about the primary care model, it was one of the pieces of it is what other pieces need to be in place. Like when we were talking about Project Echo, right, having access to specialist referrals, what are aspects of the system design that are going to make providers want to be in the system? So thinking about that along with reimbursement seems like two sides of a coin to try to avoid the situation that Rep Schmick is concerned about.
Certainly. And hearing the discussion here, I think that we'll be able to bulk up that provider participation and incentives section quite a bit. So thank you for the comments here. I'm seeing that we're right at time.
Can I
have one more slide?
Can I just ask one comment? It's a work item. I'm so sorry. But you may be able to pass it off to the legislature staff. We should do, looking at legislative bills, especially that have come through healthcare committee and been squashed by big lobbyists. Did I say that out loud? Because there's been, if you go through those, like what I mentioned, some of the bills that providers came to us about, making it very difficult for them to keep their private clinic doors open because they can never count on reimbursements and what they will be. Looking at what these bills are will also tell you some of the things that we might need to address in this proposal. Just because they didn't become a law does not mean they weren't valid concerns by healthcare providers. And I think the last 10 years, a look-see of those would be helpful. And like I said, you might be able to work with the committee staff and say, hey, what especially healthcare. Can you give me a list? And you got a chair of the Senate one there. And I just saw her nod and smile. So there we go.
Fantastic. Thank you for the suggestion and for the help as well. So looking forward to addressing that. And with that, I think I will hand it back over to either Mary or Chair Lowe to close out the meeting.
All right. Thank you, Harrison. Thank you, everybody. Thanks to all the people who came in person. It's nice to see chairs full of people in here. The recording and summary for this meeting will be on the Universal Healthcare Commission page of the Healthcare Authority's website. Our next meeting is Thursday, June 18th from 2 to 5 p.m. We look forward to seeing you there. Call the meeting adjourned at 5:02.
Thank you, everyone.
Thanks, everyone.